Uh, Dr. Krishnamurthy, Professor Satish Chandra, ladies and gentlemen, it just shows you might know a little bit about autonomic dysfunction, but you're terrible with all other things, so we need the expertise. It's really good to be here, and it's good to see an audience. And I must actually give you a health warning in a way, because you're going to be listening to me twice. So part of what I'm going to be saying again. So keep that in mind if you want to leave now and come for the other one, you see. Now, what I thought I'd do is really go through, I believe all of you are in a whole range, you're in general practice, and therefore you cover the entire components. So what I want to do is really go through, to give you some idea of the autonomic dysfunction syndromes. And I'm going to do this in two ways. I'm going to go through the scientific principles first, and we're going to focus largely on cardiovascular control. And then I'm going to give you some examples in real life and what they have shown, because I hope that this will resonate even more closely with what you see in clinical practice. So if we can begin, the nervous system, as you know, is an amazing system with cognition, with the motor side, with the sensory side. But the autonomic side, and I might have a bias here, of course, is very important because it serves every organ in the body. And as you probably know, it's both in relation to what's called the sympathetic, which goes to each organ, and the parasympathetic from the brain and the sacral region. As a result of which organs are innervated and function well. There's integrative function in terms of temperature control and blood pressure control, and it's so important for well-being, for emotion, and quite importantly also for survival. If we didn't have our blood pressure and our temperatures, two examples, well controlled, we wouldn't be around. This is a brief description of the cardiovascular components and a classification. And these are clearly people who would present with either dizziness or with syncope, particularly when they change position. And you can divide them into two sorts. The upper, which are patients where there is damage to the autonomic nervous system. Unfortunately, many of them we cannot reverse, but we can certainly treat, so it's important. And then those where you've got an intermittent disorder, where there's no damage, but it occurs for a short while. And I'll give you some examples of these. Now, we normally think of blood pressure as that magical figure of 120/80, and don't usually think of the fact that the heart is important to keep that pressure up. The blood vessels are important, the volume in it. But what is not shown here, and I'll show you in a moment, is that with each beat, the autonomic nervous system controls blood pressure and heart rate in a variety of situations. This is a very simple diagram schema of what's called the baroreflex, which controls blood pressure. You've got signals from major arteries and the lungs which go into the brain. In the brain, it's integrated. And this is done automatically, of course, by the autonomic nervous system. You've got the vagus nerve to the heart, which either raises the heart rate when the blood pressure is low or lowers it when the blood pressure is high. And then you've got the nerves coming down the spinal cord. These are the sympathetic to the heart and the blood vessels, which constrict when needed to keep the blood pressure up or dilate and expand to lower the blood pressure. And this is occurring all the time. Now, just to give you one example, that there are chemicals involved also, so it's both neural activity and humoral or chemical activity, and I'm just going to point to one or 2 points here in this slide. In a normal group of subjects, this is the noradrenaline level, which is the precise marker of autonomic sympathetic activity, and it goes up when people are standing. In various conditions, you'll see that there's no change in this. So there is failure of the autonomic nervous system. I'm just going to show you two, a brother and a sister, where there was absolutely no level, detectable level of noradrenaline or of adrenaline, which is usually much lower. And we'll come to that in a moment. But the key is noradrenaline is the neurotransmitter which helps in constriction of the vessels. Now, you can test this in a variety of ways, and I'm not going to go through this. You need modern technology, you need tilt tables, you need good laboratories, and of course, you need very good supportive staff who are going to help in terms of this. And I'm going to show you an example of what we can see these days, because we don't need to put in catheters into the arteries. We can do this non-invasively, and we can measure blood pressure continuously. Here's before, during head-up tilt. So we've got gravity and after head-up tilt. And there's virtually no change in blood pressure and heart rate in a normal individual. Now, this is what happens in different situations. And you all are lucky you're sitting, but in my case, I'm standing. So we've got gravity. So it's very important that I have the right blood pressure to get blood, particularly to the brain, so I can function reasonably well. Now, if there's damage to these autonomic nerves, this is what happens. You get autonomic failure, and the moment they're put upright or standing, the blood pressure plummets down. The moment they're put back to the horizontal, it goes up, sometimes even higher. And the nerves to the heart are not working well, so the heart is effectively flat. So that's a typical example of orthostatic hypotension. And there are two important clinical pointers here. The first is check with your patients, are they worse when they're upright, and are they better when they're lying down? And measure the blood pressure and ideally heart rate when they're lying flat and when they're sitting or standing, because that's the only way you can pick this up. History and the findings, and then, of course, the laboratory, which helps. Now, you're going to say, does it matter at all? And the answer is yes, because these are some of the symptoms which occur if you're not getting blood to the brain, which is above the heart and therefore more susceptible when you're standing. You get dizziness, visual change, you might faint, and people don't think clearly. You can get pain in a region known as the coat hanger region. This is because they need, these muscles to the neck need blood. And if you do not get it, you get pain there, because we use this all the time, otherwise my head will drop down. There can be less urine when they're upright because you're not getting enough blood pressure to the kidneys. And it's worth noting that you may not have these, but you may have a whole range of non-specific features: weakness, lethargy, fatigue. And of course, what is very worrying, particularly in older people, is you can get trauma. As in this patient, as you can see here, she almost lost the sight in her right eye. She had trauma to the head. She had a minor cerebral bleed. And this was missed because nobody was taking the blood pressure lying and standing until she came to us. Now, we know it's not just standing up which can do it. Due to the research in various laboratories and ours, we know that many factors can. Forgive me for this busy slide, but just to point out that in anything which dilates the blood vessels and expands them can make matters worse because the nerves are not working properly. So when it's hot, because of cutaneous dilatation, after food and even small amounts of alcohol, because of splanchnic dilatation, and after physical exertion, because you need more blood flow to the muscles. And it's also worth noting that a whole range of drugs, and so the drug history is very important to ensure that drugs are not responsible for that too. There are many ways of testing, which there's no time to go through, but I just thought I'd show you that one thing which could be used in the home situation is what we call an ambulatory blood pressure. You put a cuff, this is programmed, it automatically records every 20 minutes. There's also an override in particular situations. This is in a normal subject. You've got a few changes depending upon activity. At night, it drops down, and that's a perfectly normal response because your sympathetic nerves, which are working well, switch off a little bit at night. If you have a patient who's got autonomic failure, this is what you see. Blood pressure is going up and down. And if you look at this with a diary, and this is where our particular autonomic protocol comes in, you find that they're lying flat here, they're standing up, they may be having food. This is in the evening after dinner. And at night, it goes up even higher. So you may have another problem, which is called supine hypertension. And please note here, many of them pass urine overnight. The moment they're trying to pass urine, the blood pressure drops down again. So these are the aspects which you can pick up using a standard 24-hour blood pressure, but with the protocol. I'm going to give you an example now for two cases with fixed autonomic failure. Maybe I shouldn't have said that straight away, because I'd like you to think about it too. So this is a 59-year-old lady. She fainted on 2 occasions, not while walking flat, but on a slope. She was weaker over some years. She was worse after food and in hot weather. She had pain in the neck region, but this occurred only when she was upright, not when she was flat. So it wasn't due to cervical spondylitis. She did not perspire, so she was not sweating. Unlike previously, she had been constipated. And I bring this out because, of course, the autonomic nerves supply sweat glands, supply the bladder, supply the gut too. On examination, there was nothing to find clinically, no neurological or other deficit, except that when she was stood up, the blood pressure fell quite markedly. So again, the clue came there. You obviously know what the diagnosis is. It's easier for me because I know what. Thank you very much. Am I getting too hoarse? Is that the clinical diagnosis? This is a condition where you get pure autonomic failure, which means there's only the autonomic nerves are involved, with severe orthostatic or postural hypotension. I'm going to give you another case now. This is a 68-year-old gentleman who became worse usually after meals for some years. He couldn't even drink a small amount of alcohol, so even half a glass of Kingfisher Light and he'd be in trouble. He had erectile failure, he was constipated, his handwriting became smaller, his balance was poorer. Clinically, he had Parkinsonian features, but he only had a small fall in blood pressure in the clinic, so he didn't really have postural hypotension by definition, which is over 20. Now, what could the diagnosis be here? And it's different from the other ones. The diagnosis here is that he had Parkinson's disease, hence his motor deficits. He also had autonomic failure, which caused orthostatic hypotension, but not usually when upright. It was mainly after food. So the history was important, and also the fact that you can be testing them in the laboratory. Just to give you some examples of these sorts of conditions, they could be acute, which are fairly rare. They could be chronic. We've given you two examples: pure autonomic failure, Parkinson's disease. There is a rare condition called, or relatively rare, called multiple system atrophy, where there's more than Parkinsonian features, and unfortunately the prognosis is quite poor. It's difficult to separate, but it's very important to diagnose. And increasingly, as we find in the elderly, there's a condition called Lewy body disease. So they might have some Parkinsonian features, they don't think, so there may be a touch of dementia, and they've got marked autonomic failure in some of them. So these are conditions which should be picked up and therefore treated. These are what we call primary, but there are a whole range of what we call secondary, where we know what the condition or the cause is. They may be genetic, and some of them are relatively rare, such as those patients with dopamine beta hydroxylase deficiency. Those are the ones where the noradrenaline was 0 on that slide. It could happen to any of us due to trauma, high spinal cord injury. It may be a very common metabolic condition. And Krish, thank you for your slide the other day that 20%, I think, from Dick's Mayo Clinic Laboratory with neurological and possibly autonomic conditions. And of course, we talked about drugs which can cause it. Now, I just showed this briefly. I'll just give you one or two examples of treatment, by the way, but the doctor, of course, should know what the cause is and what the mechanisms are. And of course, these days, increasingly, the patients, they've got recourse to the internet, so they can learn as much, sometimes even more than the doctor does. And I said there's no time for this, but there are a whole range of factors, non-pharmacological, and you're very fortunate that in Chennai that there's a whole range, and I'm pointing to Dr. Krishnamurthy and his departments which have been evolving things. There are a whole range of drugs which can be given to help with this. I'm just going to talk about one drug. Before that, drugs are expensive, of course, anywhere. But sometimes there are fairly simple, cheap methods, one of which is 2 glasses of water, which raises the blood pressure. Surprisingly, no time to go into the details. And I think somebody asked when this was seen, this is part of our back garden, as it were. But in England, of course, it rains all the time, but it hadn't rained at the time, so it's actually quite dry over there, which is why I thought it would be useful to put that up. Now, we talked about those patients, very rare, with dopamine beta hydroxylase deficiency. This is where this enzyme here is missing. And it's important because if you look at the formation of noradrenaline, the chemical we talked about in adrenaline, It comes from various substances, but the precursor is dopamine, which is converted by this enzyme into noradrenaline. Now you might say, what's the fuss about? Just give noradrenaline by mouth. But you can't, because it's chewed up in the gut, just like dopamine. So there is a drug, which years ago we managed to get from Japan, which is converted by this enzyme into noradrenaline. So it bypasses the deficit and is very useful. So it's now the only oral drug which is a replacement therapy for noradrenaline deficiency. And I'll just go through this quickly to show you what happens in Parkinson's disease. This is with levodopa. It's converted into dopamine, so you can give it by mouth because of this enzyme, dopa decarboxylase. The same with L-DOPS. You give it by mouth, and it's converted into noradrenaline. So this already has, and I think is going to make a tremendous amount of difference to the management of these patients. I quickly add that it's taken a long time to get this through. It's just been approved by the FDA in the United States, and it's up before the European Drug Authority. And so these things take time, but it'll make a lot of difference. And I give you one example here of an ongoing study, but even at this early stage, this is in Parkinson's disease with autonomic failure. You find that when you give placebo, that's the number of falls, and you can more than halve them when you give the drug. Keeping in mind that, of course, falls in Parkinson's are also due to the motor deficit, so it could be even more effective when you don't have Parkinson's. What are we trying to avoid? You've seen that slide, the trauma to people. And I show you this slide, which will come up again, in fact, although it's for a different condition. You can actually have a break. This is a patient of mine who had a break in the dominant arm of the humerus and fell. And he was perfectly independent, but because of that became quite markedly dependent. And of course, to the individual, to the family, and financially, it's a big burden. Now, I'm going to give you some examples of intermittent disorders. And just to emphasize, these are conditions where there's no damage, unlike the other ones with the neurons, but there's a short-lived problem. Why this occurs is a lot of it is up for grabs, but let's see this. This is now a 17-year-old girl. She used to faint when she went to church and had what they considered to be fits, and she was put on anti-epileptic drugs for a long time, which caused quite a lot of problems, and then they realized it was having no effect, causing side effects, and that was very likely the wrong diagnosis. A history of faints before, the warning was variable, she had damaged herself, she promptly recovered when she was flat. There was a family history of fainting, and the only thing to find was she had a low blood pressure, but without a postural fall. So you're going to wonder what the diagnosis is in this condition. We know it's not epilepsy. And this is what was seen when she was tested. When she was put on the tilt table and in the laboratory, there was no fall in blood pressure. But the moment she saw a needle, and they had the needle, down came the blood pressure, down came the heart rate. Now, these nerves are functioning, but for some reason, the sympathetic nerves to the blood vessels dilate. So the blood pressure falls because the vessels are dilated. And for an unknown reason, the vagus nerve overreacts and slows the heart rate. So that's known as autonomic mediated syncope. Also, in the subgroup here is vasovagal syncope. And so that's the diagnosis in this case, autonomic mediated syncope and vasodepressor predominantly. So this patient shouldn't have a pacemaker. And this is very important. In the old days, in our experience, a lot of them would go almost automatically to have a pacemaker, which was, again, horrendously expensive and unnecessary. But you need to be sure. Okay. This shows the difference of why you need the methodology and techniques. When you've got orthostatic hypotension, it remains low for a long period, so you can measure it even with the standard blood pressure cuffs. With syncope, you do need the technology to pick it up readily. Some may say, why do you bother about testing? Because a lot of these people have faints and they get better as they grow older. And it's true, the majority. But if you're getting recurrent faints, you need to investigate to find out which type it is. And this is one example. This is one such patient where the heart rate, as you can see, boom, went right down. So that's known as the cardioinhibitory form. And this patient is the sort who must have a pacemaker. So it should go pretty well to the cardiologist, and have a pacemaker put in. I'm going to give you another example. We talked about that 17-year-old man who had the fracture. He had fallen. He'd had blackouts for no reason at all. One occasion it was related to shaving. No previous medical history and nothing to find except for the injury. So we're going to say, what is the diagnosis there in this gentleman? And you've seen that before. So I'm going to go through this. And now, we tested him before I go into that, and we couldn't find anything. So he didn't have orthostatic hypotension. We couldn't induce anything on the tilt table. He didn't have vasovagal syncope. But the only thing then we had to think of, because he's in the right age, unfortunately, as we get older, many things tend to be less effective, particularly in the nervous system. But for some curious reasons, the nerves in the neck become more sensitive. They feed the information into the brain, you will recall, you see, in terms of maintaining blood pressure. And in this particular gentleman, as I think I've lost the, you can see that the heart rate drops the moment he's had unilateral carotid sinus massage. Now, I quickly add, before you do that, it's very important to make sure that there's no atheroma, no plaque, you're not going to cause a stroke, and so on, you see. But this is an example of carotid sinus hypersensitivity. He was a very unusual case. They're usually bilateral, by the way. He underwent denervation of that by one of our surgical colleagues, and it had nothing to do with that. He became president of the Royal College of Surgeons later, you see, and was knighted. But it just shows that you can do a unilateral, but in the majority, you do need a pacemaker to help with this. So that was the diagnosis, carotid sinus hypersensitivity. And I'm now going to go on to the last case of a 23-year-old lady, and you might say this is unique, referred by a cardiologist, but this is increasingly so now. She had dizziness when she was upright. She had palpitations, usually, when upright, and even after mild exertion. She was quite fatigued. She also had headache, which was worse when she was upright. And only on examination, essentially nothing to find. So no neurological or cardiac, except that she had a marked rise in heart rate of over 30 beats per minute. So lying, say it was 80, upright, it went up to 116. I mean, it really should go up by about 10 or 15 only. So what's the diagnosis? And this is what was seen in this sort of a patient. Normally, you get no change in blood pressure and heart rate. In this patient, the blood pressure is low, but it's not falling, unlike the other patients. But look at the heart rate. It's going up quite markedly when upright, and then comes back when they're sitting down or lying down. And this is called the postural tachycardia syndrome. And this is a disorder which now occurs in young people. It's really been described since the start of the millennium, so in the last 10, 15 years. This is what you might see when you use the blood pressure machines and the heart rate machines we were talking about. Normally, I'm not sure what's happened to the L there, it should be there, you get, well, small changes in blood pressure and heart rate. In a patient who's got POTS, it's going up and down. And you're going to find out why. This is why it's so important to have the diary, which I don't think, sorry, I'm going to see, no, the diary, but if we go back to that slide, if you check on this over here, you'll find that they're standing up each time or exercising. At night, when they're lying down, of course, you don't get it. So that's typical of the postural tachycardia syndrome. In the old days, I used to call this the Manhattan skyline. In the present days, unfortunately, it's the London skyline. No, I should say fortunately, it's a measure of that. And I don't know about the Chennai skyline. We talked about the Bangalore skyline a few days ago, which is catching up. So the diagnosis here is the postural tachycardia syndrome. I won't be going into further details on this because we'll be talking a little bit about this later. But I just want to make one point. There's one strong association that we've found. And this, I give you an example of a patient who's a nursing sister who had followed up for many years. And when she came up later, we knew we'd find out what the cause was in due course. She came to me and said, did I know that she was a very good dancer when she was young? And I said, no, I don't usually ask these questions in the outpatient clinic. And she said, she was in her late 40s, early 50s. And she said, this is what I can do. This is in the audiovisual department, by the way, not in our clinic. And she could do that, and I was reasonably impressed, because I certainly can't do it. And she could do that, and she could do that too. Now, none of you are impressed, because I'm sure you can all do it possibly, but she had what's called the joint hypermobility syndrome. There are many ways to evaluate it, and one way is to try and get your thumb. You can test yourselves while you're here against your forearm. If you can't, like I am, if you can see the skyline there, then you don't have, the chances are you don't have it, but so that's one thing. We know now there's a very strong association between various, it's a connective tissue, well, condition, I wouldn't even call it a disorder, condition, because some people are top athletes, gymnasts, dancers, ballet, Bharatanatyam, and so on, with no problems at all. And it's part of a condition called Ehlers-Danlos 3, which there's no time to talk about. So this all forms part of what we call the intermittent disorders, which are actually very common. So syncope, the first, can affect a large number in the population, and we now know that this is an underdiagnosed, underreported, this is about POTS. Oh, I'm sorry to put this up. I don't know, it slipped in, by the way. If I know I've gone through it very quickly, you can always go and look up some of the details. This is one of the books in terms of the autonomic nervous system, you see. So I think at that point, I would like to close, and I hope I've given you some idea of the disorders, fixed disorders and the intermittent disorders, given you some examples of what goes wrong and why, not had time, obviously, about treatment, but also given you some real examples in life as to how these patients present to you and how you should consider the diagnosis and then move forwards. Thank you very much indeed.
Questions?
Yeah, that's fine. I'd be delighted to answer.
If you have any questions, this is a good time to ask Professor Mathias a couple of questions before we move to the next talk. Dr. Vijay Kumar.
I would like to have your comments on a biofeedback technique done by California Institute of Heart Math on heart rate variability studies. They have a biofeedback equipment using just breathing technique, a deep inspiration and expiration, and this is connected to the computer. And with deep breathing, they are able to stabilize the sympathetic and parasympathetic. This technique is used not only to stabilize for a lot of conditions and cardiac conditions, but it's also been useful in hyperkinetic behavior disorder, children, because they connect it with games, computer games. With your breathing, you're able to bring down your hyperkinesis and regulate your breathing, balancing the sympathetic and parasympathetic. If you're basically having a high sympathetic, you get red bars going up. But if you have medium, it's blue bars. If you have good breathing with balanced breathing, then you go to green bars. I have this equipment with me, and I find it very useful in a lot of psychosomatic conditions like irritable bowel syndrome, palpitation, and things like that, where, if you ask them to do pranayama and deep breathing, there's always a reluctance. But with technology, and if you can show them the changes that's happening, they are very impressed. And then if you combine this with a little right brain activity like music, they'll then see that with this right brain activity, they're able to reach the green much faster. And then they know that this is brain and the autonomic nervous system pushing them into normality. I would like to know whether you have some thoughts on this. Thank you.
No, thank you very much. You've raised a very important issue, and I think you're absolutely right that this is useful. The chances that it will not be useful when there's actual neurological damage and the disorders which we have, the chances are it's going to be less likely, but there's no reason why it shouldn't be used because, of course, it's non-invasive. There are no side effects, unlike, unfortunately, most of the drugs. Well, every drug that we use has got side effects. I think this could be particularly useful in the patients with the POTS, with the tachycardia, because they fall into broadly three categories. Some where it's very much what I call organic or physical. So they do need drugs, they don't need anything else. And some of these are people in very high-flying situations, by the way. So I don't think they'd even accept the fact that they could be the mind coming in. There is a second group which is just the opposite, which are really the anxious, people where I'm very sure it will be. But there is quite a lot where it's the combination of the two. So you've got both the physical, organic, and the mind coming in. And I think there's a very big role to play, and this was something we discussed yesterday with Dr. Krishnamurthy and various other colleagues, you see, about the importance, including, as you put it, yoga and various other techniques, because it's very clear that there's a respiratory component to heart rate control in particular, and also blood pressure. In fact, this is part of our testing, the Valsalva and other maneuver. So using it therapeutically, I think, is certainly a very sensible way, and more should be done. Thank you.
Dr. Kamakshi Shanbhog, could you kindly clarify the association of Parkinson's disease, autonomic dysfunction, causal, coincidental, genetic?
You ask a very good question, in fact, about is it just coincidental? Now, Parkinson's disease, was and still is considered, it is a major motor disorder. It's obvious, you can see it. You don't have to be a card-carrying neurologist sometimes to make that out. And for years, the autonomic component was disregarded, for reasons one of which is that nobody measured the blood pressure lying and standing. And so the falls were considered to be due to the motor disorder rather than due to anything else. In fact, one of the people who's been instrumental, along with a number of others, is somebody called Ray Chowdhury, who did his MD with me. I think you might know him, Dr. Chandra. And he has been one, amongst others, who's been looking at the non-motor side of Parkinson's disease. And patients found that the most distressing. And most of them are autonomic. Orthostatic hypotension, the gut constipation, the bladder problems, sometimes sweating problems. You're going to, of course, say, could it just be coincidence? But then there is somebody called Braque. Braque and his wife were neuropathologists, and this is called the Braque hypothesis. And I've got my slide somewhere there, but I didn't put it in here. They did some very interesting studies and showed that there were Lewy body and Lewy body neurites occurring even before the motor features in the brainstem of Parkinson's to be patients. Parkinson's to be, I say, on the typical. So this has been neuropathologically shown by Braque, occurring in the autonomic neurons in the brain, the various brain areas and further, as a precursor to the substantia nigra and the basal ganglia involvement, which is very clearly motor. So it's not coincidence, it's reality, it's part of the condition, and in fact it may be a precursor to the motor deficit in Parkinson's disease. I hope it answers your question.
Thank you very much for an excellent lecture, sir.
Thank you.
One last question and then we will move on.
Can you just elaborate a few points between the relationship between diabetes and autonomic disturbances?
Thank you. My own personal experience, by the way, as you'll probably hear later with diabetes, I've tried to keep diabetes away because our department will be swamped, and the reason being that diabetics are, unfortunately, the incidence keeps going up, and as we heard yesterday again from Dr. Krishnamurthy from the Mayo Clinic studies, 20% of them certainly would have a neuropathy, and the majority would also have an autonomic neuropathy. So huge numbers. It's very likely, not very likely, it is damage to the autonomic nerves. It seems to occur first in the heart. So one of the first things is a cardiac autonomic neuropathy or denervation, and then it's the sympathetic. So patients may not have the fall in blood pressure at the start of the condition, but with the testing, they've got the problems with the heart. And this is of some importance because various colleagues in Michigan have shown using a number of studies that the cardiac control, the coronary control, is actually much poorer in these patients. So when you've got that, when you've got diminished heart rate variability, which is one way of testing for it, the incidence of death is much higher. So I think it's, not just a number of people feel that this has been under-investigated, under-considered, and could have major influence in terms of management of diabetics, particularly when they've got a neuropathy. I hope that helps partially answer the question.